and Susan G. Komen. A big question in the field of breast cancer is, do all patients need an aggressive combination of surgery, radiation, and chemotherapy to effectively treat their disease? Doctors have learned that some patients do well with less intervention, an approach we now call treatment de-escalation. To discuss recent breakthroughs in treatment de-escalation, with me today are experts in the field, Dr. Daniel Stover from Ohio State University and Dr. Antonio Wolff from Johns Hopkins. Welcome.
Thanks, Victoria.
Thank you.
So, many patients know that the side effects from chemotherapy are, frankly, awful. But luckily, there have been huge advancements in identifying who can safely skip chemotherapy, particularly those with estrogen receptor positive breast cancer. But what about other types of breast cancer? Let's hear from Dr. Wolff, who is involved in some of this research. Dr. Wolff, what is on the horizon for patients with HER2 positive breast cancer?
We now, with HER2 positive disease, we are slowly and surely reducing the amount of chemotherapy that patients need to get. And so when trials of HER2 positive disease and the approval of the drug trastuzumab, that is commercially known as Herceptin, became available around 2005 for patients with early stage disease, at that moment we were giving antibody therapy, trastuzumab, against the HER2 receptor with 3 chemotherapy drugs. And then we realized we didn't need 3 chemotherapy drugs. We could get away with 2 chemotherapy drugs only. And now we have a situation that for patients with stage 1 HER2 positive disease, which means patients who have a tumor that is no greater than 2 centimeters, so 2 centimeters or less, and don't have involvement of lymph nodes in the axilla, what these patients need is a little bit of chemotherapy alone, and they often receive a drug called paclitaxel in combination with the antibody trastuzumab. And what we are learning today is that after 10 years of follow-up, the vast majority of patients, approaching 98% of patients, are alive without issues. And that is a dramatic improvement in what we have done and achieved so far.
So it sounds like less is more has really been optimal for this group of patients. So that is really promising news for those with HER2 positive disease. But Dr. Stover, how about those with triple negative breast cancer? We know that chemotherapy remains the standard of care for TNBC, but is there any hope for chemo optimization for these patients?
Historically, as Dr. Wolff mentioned, we would typically treat aggressive triple negative breast cancers with 3 chemotherapy drugs, one of which tends to be part of a class of drugs called anthracyclines. And anthracyclines have historically been a great advance for breast cancer treatment and have likely cured many women, but they come with some long-term potential side effects, including potential impact on the heart and on the bone marrow later on after receiving treatment. And as we have gone forward, similar to HER2 positive breast cancer, the question has raised, are there alternatives, or do all patients truly need all 3 chemotherapy agents and/or chemotherapy agents like anthracyclines, which may have some side effects we would like to avoid? And there have been several efforts to look at regimens that do not include anthracyclines and try to identify those patients who can get away with less to right-size them. One of those that is sort of at the cutting edge is the NeoPact trial, which includes a taxane chemotherapy, a platinum chemotherapy, carboplatin, and immunotherapy, or treatment to activate the body's immune system to help fight the cancer. And these are building on several trials over the last decade that have looked at this combination of these taxanes and carboplatin as the backbone of the chemotherapy. So two chemotherapy agents, neither of which is an anthracycline, to potentially get outstanding results. And we know from earlier studies, the WGS ADAPT, and an earlier trial by the same group that's doing NeoPact, that taxane and carboplatin have very good response rates in triple-negative breast cancers. So I think that we are still trying to identify which patients can avoid the anthracyclines. But I think the other approach that we're starting to take is letting the treatment tell us who those patients are. So starting with sort of a more backed off component of the therapy, seeing how they respond with surgery. And then if we need to do additional therapy after surgery, then we can tailor the optimal treatment for those patients.
This is all really great news for patients, especially in getting away from the concept of one size fits all. Everybody knows that's not true, and that's definitely not true in treatment as well. This is terrific news that this optimization could be available to even more patients soon. So we know since 1985, some patients have had options about surgery. We're talking about breast conserving surgery as opposed to mastectomy. There's some other factors that patients and their doctors need to consider. So there's been some new research out there that's pointing to new decisions that can be made. So Dr. Stover, why don't you tell us a little bit more about that?
Thanks, Victoria. In the same way that we're trying to identify just the right amount of medical treatment for patients with breast cancer, there's also great efforts to identify the right amount of surgical treatment for patients. One of the areas that's been a longstanding question is if a patient has multiple breast tumors within a single breast, is a mastectomy or removing the whole breast the only option for those patients? And there's some recent data, the Z1102 study, that was an early study that suggests that some of these patients may be able to undergo lumpectomy or breast conserving surgery with excellent outcomes. So this is an exciting area to try and optimize the amount of surgery and potentially avoid mastectomy in patients who prefer breast conserving surgery.
There's also some indications for patients who are looking at lymph node removal. And I know many patients have experienced the side effects of lymphedema. This is the buildup of lymph fluid in the fatty tissue that's just under the skin, and it causes a lot of swelling and discomfort. Happens in the arms and legs primarily, but also can happen in the face and neck and other parts of the body. So not a great outcome for patients. So what other trials are underway to help better identify patients who can avoid that?
Absolutely. It's really important to understand in what patients we can limit the number of lymph nodes that need to be removed from the armpit to minimize these long-term toxicities like lymphedema. Historically, all patients 20, 30 years ago had all of the lymph nodes removed. But work from the Z11 study in particular suggested that many patients could only require a sentinel lymph node biopsy or sampling 1 to 3 lymph nodes that drain from the area of the breast tumor. There's an ongoing study currently called A011202 that's looking to see how the interaction of removing lymph nodes and radiation might interplay. So for patients who have a positive lymph node, do we need to both remove all the lymph nodes and give radiation? Or is there a subset of patients that if we only remove 1 to 3 involved lymph nodes and give radiation, is that good enough that patients have good long-term outcomes, but with less toxicity? So I think that trying to right-size the amount of surgery, not only in the breast, but also for the lymph nodes, is something that could improve long-term outcomes for our patients in terms of the potential side effects from those surgical procedures.
This is great. These are great outcomes, but also a great quality of life for patients, which is so important. While we just heard that radiation plays a key role in surgical optimization, There are also efforts to pinpoint ways to reduce the amount of radiation therapy given to patients. Dr. Stover, you're also involved in a very exciting study designed to safely reduce radiation treatment for estrogen receptor positive breast cancer patients. So tell us, what do patients need to know?
You're exactly right, Victoria. We know that some patients with small lymph node negative, estrogen positive, and HER2 negative breast cancers have excellent outcomes. In fact, the majority of patients have excellent outcomes. But the question has come forward whether some of those patients actually may not require radiation in addition to effective anti-estrogen therapy, the daily pill that's standard of care for these patients. The DEBRA study, which is ongoing and enrolling patients, identifies those that have small lymph node negative, estrogen positive breast cancers, and their tumor has undergone an additional molecular test that identifies it as low risk, that it doesn't have features of high-risk cancers. And patients are then randomized to either receive radiation and their standard endocrine therapy or endocrine therapy alone, with the investigation of whether we can use the combination of small tumors that are lymph node negative, but also this molecular test with good anti-estrogen therapy to potentially avoid radiation in some patients. And I think this idea that we could potentially omit radiation in some patients is something that would have shocked us 20 or 30 years ago. But as we're really trying to find the right amount of treatment, but not any more and not any less for our patients, this is an important question as we get into this era in breast cancer management.
Dr. Wolff, do you want to weigh in on this new development?
I think it is fascinating that we are really moving into what many would call the Goldilocks era of oncology care. Is like the right temperature, not too hot, not too cold, and really to find out what is the treatment that that individual patient needs. And it is a combination of traditional, what we call anatomic parameters, what the pathologist could measure, tumor size, how many lymph nodes, etc., but really understanding the biology of the disease, going beyond traditional phenotypes, as we call them, estrogen receptor positive, triple negative, HER2 positive, but refining that even more. We are all specialists in our individual instruments, but we need to understand how everything plays well together so that we can ultimately deliver for patients the best care they need at that moment, and hopefully perhaps even participating in a clinical trial. Even though breast cancer, there's no such thing as, it's incredibly stressful for patients and loved ones, but all of us working with patients and researching these issues, we could not be more excited to be where we are today, where treatments continue to improve and outcomes continue to improve.
That was a fantastic final word. I think we're going to be using the term Goldilocks as the goal for treatment experience. I'm going to take that from you, Dr. Wolff, and use that. What patient doesn't want to know that there is a team behind them striving for that Goldilocks experience where everything is just right? What a goal to have. I want to thank you both so much for being here with me today. It is so inspiring to hear about all the ways researchers like you are leading the way in precision medicine, truly tailoring each aspect of treatment to each and every individual patient. And I want to thank everyone for tuning in at home. At Susan G. Komen, research is a priority in the fight against breast cancer, and we've invested more than $1 billion toward these breakthroughs. So head over to the Breast Cancer Breakthroughs webpage, where we've linked below, and you can sign up for updates about future episodes. And we look forward to sharing more exciting advances in breast cancer research with you.